afternoon. I see that it's 12. So let's begin. I would like to let everyone know that this session is being recorded, and these recordings will become available on our Dent Echo website after session. And we are very excited to have everyone join us for the 23rd Dent Echo. This session is brought to you by the UT Health San Antonio School of Dentistry. I'm Kato, and I will be assisting in facilitating today's session. And here is our agenda for today. We'll start off with some announcements and introductions, then move on to didactic presentation by Dr. Natalia Kajimoto, and case presentation by Dr. Kathleen Gable, with time for Q&A at the end. Next slide. Thank you. And some notes, quick notes before we get started. These sessions are recorded for later distribution on our Dent Echo website. Please stay muted unless you are speaking, and you can also use the chat to raise questions and share your perspectives. The slides and recordings will be made available on our Dent Echo website after session. And to help us with attendance, please enter your name and organization into the chat. And please remember that no personal health information is allowed in either the chat or our discussion. And if you would like any assistance with your connection throughout the session, please chat Angela, our Dent Echo IT. Next slide. And for those who may be new to Echo, this is a model that builds virtual communities of practice and learning. And sessions include a didactic presentation and de-identified case-based learning, and group discussion to foster deep knowledge and build individual capacity. Echo is an all-teach, all-learn supported model, and Echoes thrive on the interaction from the full learning network. And so we encourage everybody to participate in the conversation today. And we also encourage you to join by video if you can. Next slide. And to receive CDE credits, please make sure to be on the session throughout the duration of the presentation. And if you would like to receive CDE credits, make sure to register through Smile, which you can do so now using the link in the chat, or by scanning the QR code that you see on the slide. When registering, please use the supercode ECHO 2024. Thank you, Angela. Please unshare the slides. And with that, let's do some introductions. Dr. Challa.
First of all, thank you all for taking the time to attend. And thank you, Dr. Gable and Dr. Kajimoto, for today's presentation.
Thank you so much, Dr. Challa. And from the Hub team, we also have Dr. Marwaha, Dr. Dar, and Kathleen on today. I will now pass the mic over to Dr. Dar to introduce today's speakers, Dr. Kajimoto and Dr. Gable.
Thank you so much, Ms. Kito. Hello, everyone, and thank you so much, Dr. Gable and Dr. Kajimoto, for your valuable time. I have some technological difficulties where my microphone is not working. Hence, Kathleen was kind enough to share her computer setup with me. Welcome again, and thank you for your time. Dr. Kajimoto was born and raised in Brazil. She received her DDS, MS, and PhD specialty in periodontology from Sao Paulo State University in Brazil. Dr. Kajimoto also has a specialty in dental implants and completed a postdoctoral periodontology at the New York University and Sao Paulo State University. Currently, she serves as an assistant professor in the Department of Periodontics at our university. Dr. Kajimoto's main research activities here are aimed to establish comprehensive health promotion program that will significantly improve oral health and promote healthier behaviors in underdeveloped countries. Her research experience covers global oral health, bone and periodontal healing, biomaterials, and periodontal diseases. Welcome, Dr. Kajimoto. Dr. Kathleen Gable is a current second-year periodontics resident at UT Health San Antonio School of Dentistry. Dr. Gable was born and raised in San Antonio and later received a dental degree from UT Health San Antonio School of Dentistry in 2023. It's always a pleasure to have our alumni and current residents as speaker of Dent Echo. Thank you so much. During her time in dental school, she pursued research in implant hygiene methods and titanium dissolution as it relates to peri-implants. She has continued her research as a postdoctoral candidate and has presented her research work at different state and national and international platforms, and also have received several awards for her research work. Thank you so much, Dr. Gable, for your time. We all look forward to your presentation. Thank you.
Thank you.
Thank you, Dr. Dar. And Dr. Kajimoto, whenever you're ready, you can take it away.
Okay. Okay, are you able to see the slides?
Looks great.
Just move it here. Okay. So thank you all. Good afternoon. I would like to thank all the Dentalco team for all the support, and especially Dr. Dar for inviting us for this presentation today. That we are going to discuss a little bit about how to manage patients with periodontitis and uncontrolled diabetes. So the first part of the lecture, it's not going. Oh, if you click it'll work. Okay. So we are going to talk a little bit how to manage those patients with periodontitis and uncontrolled diabetes. And then we are going to present a clinical case of a patient that was diagnosed with diabetes and periodontal disease. So we already know that in the dental science, we have strong evidence that systemic disease are linked to periodontal disease. It was a long time ago when many systemic disease were associated with periodontal disease, and diabetes is one of them. So diabetes is a very complex disease that includes several metabolic dysfunctions that can be caused by a long-term state of hyperglycemia. That is a consequence of the decreased insulin secretion and action. Patients with diabetes, they will present a change in their blood vessels. And also diabetes appears to modify the properties of the macrophage cells that can help in decreasing the response of the to bacterial infections, and also can help on the impaired wound healing in this kind of patients. So the World Health Organization estimates by 2030 that diabetes will affect almost 10% of adults worldwide. So it's a great amount of the population with diabetes. And according to the American Diabetes Association, the last data they provided in the United States, we have an epidemic of patients with diabetes. So almost 12% of the population was diagnosed with diabetes. And they are expecting every year 1.2 million new cases of Americans with diabetes. If you look in Texas, it's not different. So we also have an epidemic in Texas, and almost 12% of Texans, they have been diagnosed with diabetes. So we need to keep an eye because we are seeing these patients here, and we can diagnose diabetes using A1C criteria, fast plasma glucose, or 2-hour glucose value. So in this presentation, we are going to show most of the studies, they looked for A1C criteria. So we consider a patient diabetic when they have 6.5% of A1C or higher. To be uncontrolled diabetes, we consider 7% or higher of the A1C. We know that we have different types of diabetes. We are not going to go over this in this lecture, but we know that we have type 1 and type 2 diabetes, and the most frequent is the type 2 diabetes. So we are going to see over the presentation that most of the studies were looking patients with type 2 diabetes. And diabetes has been associated with many diseases, including periodontal disease. So We know that periodontal disease is very common too. It's a chronic inflammatory disease that affects a great amount of the population in the world. And in the United States, it's not different again. So the American Academy of Periodontology warned about a significant public health problem because almost half of the dentate adults in the United States were diagnosed with periodontitis. So periodontitis is not a disease of the third age. It's a disease that can be diagnosed in young adults. And as the years pass by and they get older, then this number can be 60% of the third age adults having periodontal disease. So it's a very high number. And the link between periodontitis and diabetes, they are so connected that the new classification of periodontitis we use for grading the disease, diabetes as a grade modifiers. So when we say that we are grading the disease, we are looking for the rate of progression of the disease, the responsiveness of the disease to the periodontal treatment, or the impact of the disease on the systemic health. So for example, a patient that has uncontrolled diabetes, as you can see here, the A1C that it's 7 or more %, they already goes to grade C. Okay, so if you see a patient with uncontrolled diabetes, he's a grade C for the diagnosis of periodontitis. And periodontitis can have a lot of complications for our patients. And the worst one is the tooth loss. And when our patients are losing their teeth because of periodontal disease, it can have a huge impact on their health, nutrition, and well-being. So sometimes we just think about aesthetic, but a tooth is much more than aesthetic. These patients, they can have like an impact on their nutrition, and they can have bigger problems if those two teeth are not replaced. So why should periodontitis trigger the development or worsening of diabetes? So what do we have in the literature? The first thing when we look for a patient with periodontitis, especially if it's a severe case of periodontitis, we can see recession, we can see clinical attachment loss, bleeding, we can see calculus, things that are very frequent on our daily basis when we are treating patients with periodontal disease. But what we don't see is that if we take a microscope and look the gingival tissue, we are going to see ulcerations on those tissues. So it's something similar to what we see on patients with diabetes. So these ulcerations, they are like an open door to bacteria entering the bloodstream, and it can cause in a very low grade, but a systemic inflammation on those patients. So we know, and this is not new, that patients with periodontitis, they have frequent bacteremia. It could be in a daily routine, just chewing their meals or brushing their teeth. And when we perform a scaling, this bacteremia can be a little bit higher, but we know that this is occurring every day in those patients. So severe periodontitis is slightly elevate the blood sugar levels and increase A1C levels in patients without diabetes. So even patients without diabetes, we can see an impact on the levels of sugar in their blood. So this is very interesting. And this longitudinal study evaluated the A1C change over 5 years in patients with periodontitis, and they associated a progression on the A1C level on those patients. And this systematic review with meta-analysis also showed that individuals affected by periodontitis had a higher chance to develop type 2 diabetes when compared to non-affected ones. So when we see a patient with periodontitis, even though they don't have diabetes, we already know they have a higher chance to develop the disease. And this is due to the systemic inflammation that we were talking about. And this is a study to show, this is a case control study where they evaluated patients with severe periodontitis and patients without periodontitis. They collected the blood sample from these patients, and they found that patients with periodontitis had a low-grade systemic inflammation where they saw increased white cell counts, dyslipidemia, and higher low intestine lipoprotein cholesterol, and also increased non-fasting serum glucose levels when compared with patients without periodontitis. So they concluded that there is a possible link between severe generalized periodontitis and systemic inflammation, and also this metabolic state of those patients, just by having periodontitis. So what's the interrelation between diabetes and periodontal disease? So the diabetes can increase the levels of the prevalence, progression, and severity of periodontitis. On the other hand, periodontitis can influence the blood sugar control in those patients with diabetes. So it's a two-way where diabetes can influence periodontitis progression, and periodontitis can influence it can help to uncontrol the diabetes. And now when we have a patient with uncontrolled diabetes and diagnosis with periodontitis, we need to let the patient know that that's very important, so they can understand how important is the treatment of the periodontal disease to their diabetes, to their well-being, and they can be healthy. We can help. So patients with uncontrolled diabetes, they have 2 to 3 times higher risk of developing periodontitis. So there is a greater risk for severe periodontitis on those patients, and also diminished salivary flow that can also affect the progression of the periodontitis. And also they can have burning mouth or tongue. So uncontrolled type 2 diabetes increases in 4 times the risk of progressive alveolar bone compared to patients with no diabetes. According to this, it's expected that those patients, they present a greater tooth loss when the diabetes is not controlled. And what is the biological rationale linking the diabetes and the periodontitis? So it appears that it's primarily driven by the altered host response to this bacterial challenge. So we already know that patients with diabetes, they present a different microbiota. And when this diabetes is uncontrolled, there's going to occur a shift on the microbiome on this patient. So for example, patients with uncontrolled diabetes diagnosed with periodontitis, it was found an increased periodontal pathogens on their plaque, especially from the red complex species that we already know very well, the Porphyromonas gingivalis, the Tenerella forsythia, and the Treponema denticula. Also, other studies, they show that there is a predominance of pathogens in the subgingival plaque of Prevotella intermedia, Campylobacter rectus, and Porphyromonas gingivalis in patients with uncontrolled diabetes type 2. So what is the best treatment for those patients, and what are the effects of the periodontal treatment on the diabetes of those patients? So the studies, they have been showing that the periodontal treatment can reduce the systemic inflammation. So they found the reduction on the C-reactivity protein and the TNF alpha levels after periodontal treatment. And they also found that there was an improvement on the glucose control on those patients. And this can have an impact on the medical costs for these patients, because if you're helping to control the glucose, we can help to diminish the hospitalization of those patients, or we can help or we can reduce the medications those patients are taking, so we can have an impact on the medical cost every year for those patients. So this is a very interesting paper that was published where they evaluated the impact of the treatment of periodontitis on the glycemic control. So they evaluated the A1C reduction after periodontal therapy. So they found an average of 0.43% reduction on the A1C after 3 to 4 months of periodontal treatment. And then it was sustained for 0.3% at 6 months, and 0.5% at 12 months. So if we look and we think about these numbers, my first impression was, this is so low, 0.5% of A1C is nothing. But then if you do a little bit of more research, every time you have a patient with uncontrolled diabetes that it's taking one medication and the physician add a second medication to try to improve the A1C, the reduction of the A1C that they are expecting is about 0.36%. So we are providing for those patients the same reduction secondary medication would do for them. So if you just perform the periodontal treatment, reducing in 0.5% after 1 year, you're helping your patient not taking a second medication. So that's big. This is a recent randomized clinical trial where they compared the treatment of the periodontal disease in patients with diabetes type 2. So what they did in some patients, they did full mouth therapy, and in the other patients, they did biquadrant. So it was very interesting that they found that the full mouth therapy caused higher inflammation, systemic inflammation after 24 hours, as they found higher C-reactive protein levels on those patients that received the full mouth therapy. Both treatments, full mouth and quadrant, non-surgical periodontal treatment, resulted in a reduction in the A1C levels after 3 months of the therapy. But the quadrant non-surgical therapy significantly improved the absolute change in A1C from baseline to 3 months when compared to one-stage full mouth. So they indicated the treatment in patients that has periodontitis and type 2 diabetes to do the treatment by quadrant and not full mouth, according to those results. So it appears that the length of the clinical sessions will be related to the postoperative systemic inflammation. And it was also speculated that longer sessions would lead to increased bacteremia on those patients, causing the systemic inflammation. So does the presence of diabetes reduce the outcomes of periodontal treatment in subjects affected by periodontitis and diabetes? So we already know the answer, that it's yes, right? So this study performed by Jenko, they showed that in the supportive periodontal treatment, the progression of the periodontitis was significantly greater in patients with uncontrolled diabetes when compared to patients with controlled diabetes or patients that were healthy, showing a negative effect of uncontrolled diabetes on the periodontal disease progression. So what are the general considerations that we need to look when treating patients with uncontrolled diabetes? So the first thing is the same for all the patients. We need to control the acute infection that these patients have. So we need to treat the periodontal disease. We need to establish a communication with their physician to plan how to control the blood glucose levels. As we already know that advanced periodontal disease can increase the blood sugar of those patients and can contribute to make it worse, their diabetes. And we also know that poor controlled diabetes patients will have more recurrence of deep pockets and less favorable long-term response to the periodontal treatment. So when we see a patient with uncontrolled diabetes and periodontitis, we already know that we really need to track those patients and make them aware to come for the recall, come to the reevaluation, so we can keep tracking the progression of the disease and do an intervention whenever it's necessary. So when is the best time to treat this patient? So this is right away. So there is no difference with a patient that is healthy or a patient with controlled diabetes. The patients with uncontrolled diabetes also need the periodontal treatment, and you need to do it. So the procedure should be short, traumatic, and as stress-free as possible for those patients. Always prefer to schedule those patients early in the morning and make sure they are taking their medications as prescribed, and also they eat normal breakfast before the appointment to avoid hypoglycemia, because sometimes it's very frequent. The patient, they don't eat because they doesn't eat because they think it's important to be with the mouth clean or something like that, but make sure to let them know that they need to eat before the appointment. And you also need to be aware that those patients, they have a higher risk to have hypoglycemia during the dental appointment. So you need to be prepared to manage if something happened. Regarding the antibiotics, they are not necessary for the non-surgical periodontal therapy. And you're going to evaluate, of course, case by case. So in some cases, even patients without diabetes, we do the antibiotic therapy to help in the periodontal treatment. So you're going to evaluate case by case, but you don't need to do the antibiotics just because they have uncontrolled diabetes. So I'm talking about non-surgical therapy. So if you're performing a procedure that it's more invasive, so you need to rethink and look about the antibiotic therapy needed for those patients. So concluding this presentation, diabetes and periodontitis, they are epidemic in the United States. The link between diabetes and periodontitis is due to the alteration on the oral microbiome and the host response. Diabetes increases the prevalence, progression, and severity of periodontitis, and periodontitis can have an influence on the blood sugar control in those patients. And this impact is related to the levels of the fluctuations of glycemia. So if your patient have a controlled diabetes, you can treat as a normal patient. The take-home message is that dentists, they are seeing those patients more frequently than the doctors or their physicians. So sometimes they're coming every 3 months, every 6 months, or every year to your office. So we are seeing many patients with undiagnosed diabetes. So we can help. If you see something different that stand out on those patients, you should refer for a physician for a better evaluation. And if a patient has uncontrolled diabetes and needs periodontal treatment, it should be performed without delay. Thank you so much. Now, Dr. Gable, she's going to present a very interesting case about uncontrolled diabetes and periodontitis.
Thank you so much, Dr. Kajimoto. That was really informative. Does anybody have any questions or comments for Dr. Kajimoto before we move on to the case presentation part of this session? Yes, I see in the chat. Will the slides be available? Yes, it will be become available on our DentEcho website after session, and also the recording as well. Any questions for Dr. Kajimoto? If you have any questions, please feel free to type it in the chat. Let's move on to the case presentation, and hopefully we'll have some time at the end as well for more Q&As. Thank you, Dr.
All righty. So let's go ahead and get started here. So just a few things before we get started, kind of what are our goals looking at this case. We just want to be able to identify what the clinical characteristics of a patient with uncontrolled diabetes are, what are some non-surgical adjuncts to periodontal therapy, and then what is some of the literature that guides our treatment decisions when we're seeing these patients. So today we're going to be talking about this patient. This is Miss A.H. So she's a 46-year-old female who presented to me from our screening clinic here at the school. And her chief complaint was, I go to the dental hygienist every 3 months and my teeth are still falling out. Now, important to note, she had not actually lost any teeth at this point yet, but that was her concern. Medical history wise, she reported to me type 2 diabetes and depression. Her last A1C when I saw her the first time was 8.1, but she mentioned that it had been a little bit since she had been to her physician. She was taking Farxiga at the time and then reported a litany of drug allergies to me. And her blood glucose in the chair the first day I saw her was 220 milligrams per deciliter, so quite high. we'll take a look at just some of her clinical photos from the way that she presented to me the first day that I saw her. And apart from number 8, where you can see there's clearly something going on there, she doesn't necessarily have the typical presentation of the patient that you think of when you're thinking periodontitis. We don't immediately see a lot of calculus. There's not a lot of gingival erythema. It's a little bit out of the ordinary from what we would expect to see. But then we take a look at her radiographs, and this is where you start to see the underlying problem here. So especially looking at the maxilla, there's quite a few localized vertical defects in the posterior regions around her molars and premolars. And then you can see that there's a very large vertical defect on the mesial of number 8, which is, associated with that clinical presentation we saw in the previous photo. Number 15 here is practically holding on for dear life, and we can see some furcation invasion on number 31 as well. And when we take a look at the periapical radiographs, this just gives us kind of a more accurate representation of what some of those vertical defects look like. And you can see the furcation invasion on number 31 a little bit better here as well. So even though clinically it may not look like there's a lot going on, there is certainly more than what meets the eye on the surface. So this is her initial charting from the first time that I saw her. Definitely a lot of deep probing depths. There was pretty significant bleeding. And then I also was getting separation on number 8, number 15, and number 31 when I probed those teeth. She had class 3 mobility on number 8, 15, and 31, and some other generalized class 1 and class 2 mobility on her maxillary premolars. So definitely not in a good situation when I saw her for the first time. Looking at her mandibular probing, we can see this is a little bit more localized to the maxilla than the mandible if we take number 30 and 31 kind of out of the equation. But this is still definitely what I would consider a generalized case. So we did end up diagnosing her with generalized stage 3 grade C periodontitis because she's got uncontrolled diabetes. And then again, she's got these localized vertical defects, also some generalized moderate horizontal bone loss, but very minimal plaque and calculus. Her hygiene actually was not terrible. It's a lot better than some of the other people we see in our chair. And then that abscess on number 8. And so we did classify number 8, number 15, and number 31 as hopeless. Because of that, we recommended that we go ahead and extract number 8, number 15, and number 31, and then plan to start off with just 4 quadrants of scaling and root planing to try to gain some control of her periodontal disease. And then in the meantime, we were going to provide her with either an interim partial or an Essex retainer so that she was not going to ever be without number 8, because that was a very big concern of hers. Unfortunately, sometimes patients don't always agree with what you propose to them. So number 15 was hurting her at the time. So she agreed to let us take that tooth out, but she had no concerns with number 8 and number 31. They weren't bothering her. And so she said, I want to wait until after initial therapy and I want to see what happens. And so we explained to her that, at this point, those teeth had a hopeless prognosis with, grade 3 mobility and grade 3 furcation invasion. But we told her, if you want to wait and see, we can do that. And I think that actually helped to build a lot of rapport with this patient going forward. So the other thing that we decided to do, because this again is not necessarily your typical case, is we decided to do some salivary testing on this patient to see, is there anything that would guide us in some sort of adjunctive treatment, since this is not your typical case with lots of local factors. And we found that she had very high levels of those 3 red complex bacteria, which, makes sense with some of those vertical defects that we saw. So in a perfect world, I would have loved to prescribe her amoxicillin 500 milligrams and metronidazole 500 milligrams. But this patient has an amoxicillin allergy. So we just decided to prescribe her some metronidazole as an adjunct to her initial therapy, specifically because it's going to target those gram-negative anaerobic bacteria. And we were hoping that maybe she would get a little bit of a better result, since this is kind of more of a presentation of a localized aggressive periodontitis case. And then we decided to see her back at about 4 to 6 weeks for re-eval. And I know in dental school, they don't talk much about this, but some people wonder why is it 4 to 6 weeks? Is that an arbitrary number, or do we get that from somewhere? And we do get that from somewhere. There's this article by Musks that looks at the bacterial population of the periodontal pockets, and they found that it takes about 42 days for those proportions of bacteria to return to baseline levels. So that's just one of the reasons that we decide to see those patients back at 4 to 6 weeks for reevaluation after initial therapy. One of the other papers that we often cite is by Caton. This is looking at how those periodontal pockets heal after we do scaling and root planing. And they saw that there was pretty substantial improvement within 4 weeks after treatment. And that was maintained up to about 16 weeks. So that's our 3 to 4 month mark there. So again, re-eval at 4 to 6 weeks, and then we like to see those patients every 3 to 4 months for maintenance. And the reason for that is, since these levels can be maintained out to 3 to 4 months, even if the patient's maybe not doing the best job with home care, if we can see them every 3 to 4 months, then hopefully we can maintain things for them. So this is what she looked like before initial therapy. And this was somewhat anticlimactic. We didn't see a whole bunch of change after initial therapy. You can see that there's, maybe a little bit of resolution of that abscess on number 8, but still quite a bit of erythematous tissue there. And then maybe a little bit of reduction in erythema on the mandible, but not necessarily a drastic result. And her probing depths were kind of the same. There was a generalized reduction of 1 to 2 millimeters in probing depth. But nothing drastic. So at that point, what are we going to do for her? She could have been a surgical candidate, but unfortunately her finances just were not going to allow for that. So we did decide to place her in compromised maintenance. And one of the big things that we did for her was emphasizing how important her overall health was going to be with controlling her periodontal disease, because throughout the 1.5 years that I've been seeing this patient now, her A1C had gone from 8.1 to 9, back down to 8.6. She had just kind of been bouncing around this area where her A1C was uncontrolled. And just, I felt like that was having an effect on what we were seeing clinically in her mouth. So we just continued to educate her and also to encourage her, with her home care. Every time that I saw her, I would always try to find something good to tell her that she was doing, just so that she felt like it wasn't a failure. There were good things that we could point out to her. And then just continually giving oral hygiene instructions and, providing these patients help where they need it with their hygiene. So I actually went a while without seeing her. She had been really good about her maintenance visits. And then there were some financial things going on in her life. And so I went almost 6 months without seeing her. And I just recently saw her for a maintenance visit. And she was really excited when she came in. She told me she had just started Ozempic back in June, and she saw her doctor at the beginning of October, and her A1C was 6.6. She had lost some weight too. I mean, she was like a brand new person. She was so excited. And after doing her charting, I was excited too, because all of her probing depths really at this point were about 1 to 5 millimeters. The abscess at number 8 had pretty much entirely resolved. And there was a generalized reduction in the mobility of her teeth. So where we were seeing grade 2 and 3 mobility before, now there's nothing more than grade 2 mobility. It's grade 1 and grade 2. So we were really excited. And I think here, these photos, you can just see the difference. This looks drastically different than the first time I saw her. And now we can look at her charting. And one thing to point out is, where the probing depths have gone down, we have seen an increase in recession in some areas, but we expect to see that kind of as a result of initial therapy, which is why we talk to our patients about sensitivity. But overall, some grade 1, grade 2 mobility, but it's a lot less than what it was. She's still got grade 3 through and through furcation invasion on number 31, and she knows that. We talk about it every time she comes in. But at this point, she's relatively stable. So you might ask, with 31, why do we keep that tooth? Are we causing any detrimental effects to the other teeth if we keep around some hopeless teeth. And we have some literature to support that. So Moktai has looked into this, and in patients that have hopeless teeth, if we do periodontal surgery on them, they actually won't have any deleterious effects to the neighboring teeth. However, there's another study that he's done that looked at hopeless teeth and either doing no treatment and keeping those teeth around, or extracting those teeth. And he was specifically looking at the mean annual bone loss and what happened at those adjacent tooth sites. And if you kept that tooth around and did not treat it in any way, there was more than 10 times the annual bone loss than there was adjacent to those extracted tooth sites. So the moral of the story is, if we're going to keep that tooth, we've got to do something. And even though we didn't do surgery in that case, I think we've at least shown that she's been able to keep that tooth around and it's not having any effects on the adjacent teeth. So this is the moment that I love. I just feel like you can see such a difference from before initial therapy to, now after we've been seeing her for maintenance. So, where do we go from here? With this patient, I think the best thing we can do for her right now is just continue with a strict maintenance schedule. And we're actually going to try and retain number 8 and 31 for as long as possible. She's been really good with keeping up her hygiene, coming in for maintenance visits. Obviously she's taken a personal investment in her health to try and get healthier, get better. And so we're just going to continue to motivate her with that. And she knows there may be a day that comes when we really do have to take number 8 and 31 out. And she's prepared for that if we get there. But at this point, we're just happy with the progress that she's made. So does anybody have any questions for us about anything?
Thank you, Dr. Gable and Dr. Kajimoto for your for presenting on this topic. I'll repeat what Dr. Gable said. Does anybody have any questions, comments, experiences you'd like to share? You can drop it in the chat, or you can ask us. Unmute yourself and ask us. Maybe I'll take this chance to ask you and just get us started. A question. In your experience, what has been the most challenging aspect of treating periodontitis in patients with uncontrolled diabetes?
I think for me, one of the biggest things is trying to help them understand that there is a connection between their diabetes and their periodontal disease, because a lot of patients, they think, well, this is my mouth, this is my general health. How do those two things affect one another? And I think in the patients that you can help them to understand that, then it makes a big difference in them investing in their periodontal treatment and investing in their home care and their oral hygiene, because they understand the difference that it can make.
For me, I would like to add, sometimes it's very hard to keep these patients, because sometimes they keep coming like for 2 years and they are very confined, and sometimes they disappear. And they come back because they're fine. So they assume that everything is good. They don't need anymore to come every 3 months. And then they disappear and come back 1 year later, and it's a mess. So sometimes for me, it's to keep those patients like for many, many years without skipping the periodontal maintenance. And not only diabetic, but all periodontal patients.
Yeah, that's true.
Are there any, and you mentioned, Dr. Gable, during your presentation about patient education and the importance of it. Are there any resources or tools that you use that you found effective in educating them about the relationship between these two?
As far as like visual tools or anything, I don't know that there's anything as, for diabetes specifically, but I would say when it comes to like oral hygiene, I always try to show my patients, the first thing I'll do is I'll grab the mirror and you know, show them where they have plaque, where they have calculus, and make sure that not only I demonstrate to them how to floss and brush, but that they can demonstrate that back to me. Because I think it's actually really shocking sometimes how many people end up sitting in your chair and just nobody's ever taken the time to show them how to do this. And a lot of these patients are 60, 70 years old, so they're a little embarrassed. I mean, they don't want to admit that they don't know, so they'd rather just agree with you. So in that aspect of patient education, when it comes to hygiene, I think, you know, showing them what they're looking for is really important.
I have a question. This is Dr. Paleologo. Thank you for an excellent presentation, both of you. It was absolutely very informative. Do the same concerns apply for patients that have implants or are interested in receiving implants? Does diabetes affect their prognosis? Thank you.
Yes. So it affects. So for implant surgery, I would rather prefer a patient that has controlled diabetes to go for the surgery. So I would try to help this patient understand and look for their physician and try to control the diabetes first and then think about the implant therapy. But if they already have the implant and we have, for example, we also have higher chance to have periodontitis on those patients, the same as for periodontal disease. And it's even more difficult to treat periodontitis than periodontitis.
Thank you.
Thank you.
Thank you for that. And I see,
No, I agree with you on that.
and I see a comment in the chat from Violetta. Dr. Gable, can you please review the maintenance of hopeless teeth slide again? I have
Yes.
numerous patients. Yeah. So
Yeah, of
it-
course.
Yep. She says, I have numerous patients with diabetes who have hopeless teeth, but they often decline treatment because they are asymptomatic. Is there a threshold in your decision making for when you strongly encourage patients to perform extraction?
Yeah, that's a great question. So again, as far as the maintenance of hopeless teeth, and this PowerPoint will be published, so I have kind of the screenshots there for those papers that you can go take a look at and read yourself. But a lot of our literature from this comes from Moktai, and it's really the difference between treating these teeth and not treating these teeth. So when these patients have periodontal surgery around the teeth, Moktai has noted that there's really no detrimental effects on the adjacent teeth, because that's really what we're worried about, right? Is that we're going to continue to have bone loss. We'll have maybe an abscess that starts to cause more problems. And then not only are we talking about the tooth that was originally involved, but we're also talking about the, you know, possibly losing the adjacent teeth, which is a bad situation to be in for these patients. And so as long as we treat them, then we can keep them. We don't necessarily have to see those severe effects. However, in that other study where he was looking at either extracting or doing absolutely nothing to those teeth, when he kept them around and didn't extract, there was 10 times the mean annual bone loss on the adjacent tooth sites and where they didn't extract, because that's what they were comparing, is those adjacent tooth sites where they either extracted or chose to keep the teeth and didn't do anything. And that, I think, is an illustration of how bad things can be if we do nothing. So I think that's what I always try to emphasize to my patients, because a lot of them will say, you know, I'm not ready to lose this tooth. So typically my bargaining chip is, let's go through initial therapy and then let's see what happens. And if there's an abscess, you know, for example, if we can't get this abscess to resolve and you still are coming in with separation after initial therapy when I see you for a reevaluation, then we're going to have to take this tooth out. And so I'll try to come to kind of an agreement with them before we even start initial therapy on what our threshold is going to be for, you know, taking the tooth out. Another thing for me, I think, is mobility. I don't know if that's for you. 1 and 2 doesn't bother me as much, but if there's a tooth that's grade 3 mobile, that's just kind of flapping in the wind, I'll tell them, look, we'll go through initial therapy. We'll see if we can get any reduction in mobility. And if we can get that to go from a 3 to a 2, we can keep the tooth. That's great. But if we don't, then I think we need to talk about extracting the tooth. So those are kind of my bargaining chips, I guess, at least for patients, because I do find that a lot of the times it's these, people with uncontrolled diabetes, and you really want to get these diseased teeth out of there, and they're having none of it.
Thank you for that question, Violetta, and thank you, Dr. Gable. Any other questions, comments, experiences you would like to share? Has anyone here worked with a diabetic patient who have struggled to manage both their diabetes and also periodontitis? Any strategies that worked for you in improving your outcomes that you would like to share? Or any questions? We still have a few more minutes until the end of the session. Okay. All right. Angela, please share the conclusion slide. And thank you to everyone for joining us today for the 23rd DentEcho. And thank you so much, Dr. Kajimoto and Dr. Gable, for your presentation, and also for everybody for your engaging discussion at the end. Please complete the post-session survey. The link, I believe Angela have dropped in the chat. And we hope to see you in 2 months in January for the next DentEcho. Thank you again, and have a great rest of the day.
Thank you.
Thank you.